Thank you very much, Dr. Ola and Dr. Raymond, for a really very informative session. We have received some questions from the audience, and we're going to start with some questions, Dr. Junaid.
Okay. So the first question, Dr. Ola, about the oxygen delivery. Is many times it happened that the babies, especially I'm talking about less than 27 week or 28 week, that they automatically started with 50 to 60%, and then they wean it up down. Most of the time it is happening is still in the delivery rooms. And I know your recommendation, that NRB recommendation, to start with 30 maximum. But this is, I think, a physician anxiety or the nurse's anxiety. Do you have any recommendation how to tackle that?
I had a little bit problems hearing clearly, but the question was that you start with high FiO2 or high flow?
Yeah, high FiO2.
Yeah.
Most of the time in the delivery room, when the baby delivered 27 weeks, it's automatically like 60-70%, and then the wean.
Yeah. Well, of course, this is the big question to discuss now, and we don't have a final answer. But according to the survey I showed you, most of those who responded, almost 700, responded to our questions regarding not the most immature babies, but from 32 to 36 weeks. They do not start with a high FO2. Most of them start with 30% or air, a few with 40% oxygen. But I guess that if you don't have a blender, you are facing a dilemma. And there has been studies from Thailand, for instance, showing that with a certain flow, you can ascertain that you don't get too high FO2. So I'm sorry I cannot give you any more complete answer to this.
Yeah, and related to this question, Dr. Ola, that many times we notice that when we are doing procedures, for example, we bring the baby on the Cpap, baby is doing fine, but they have to put the line at that time. Let's say baby start a little bit desetting the none of the oxygen, which is also to me is not ideal, but it is happening.
Yeah, I think your question is very important, because it also illustrates how much we don't know in this field. Because I was talking about the first 5-10 minutes, and we don't have data, or not very firm data beyond that. So what I can say is that during the first 5 minutes, we want to aim at a target of 80-85% oxygen. What happens after 15 minutes or 20 minutes, if the baby needs more oxygen, we don't know. I mean, then we have to judge on our clinical experience and practice.
I have a question for Dr. Raymond. What is the maximum PIP you use for non-invasive nasal ventilation? And is there a risk of having intestinal perforation when you use high PIP or high P?
Yeah, that's a great question. I don't know if there is good guidance on the highest PIP use. I can say in our practice, we'll typically, when we're using non-invasive positive pressure ventilation, we use it asynchronously with the baby's respiratory status, and typically we'll go anywhere from 10 to 20 centimeters of water above what the PEEP is. In that Cochrane review I pointed to from 2017, they didn't show any difference in the rate of gastric perforation for an IPPV in the studies they reviewed versus nasal Cpap. So I think that is somewhat reassuring there.
Dr. Ola, there's a question about the delay in picking up the saturation in the first 60 seconds after birth. What should we do with this in this case when the pulse oximeter does not pick up the saturation? What kind of oxygen we should use?
Yeah, I mean, that is a very relevant question, and the problem with pulse oximetry is, of course, that the signal is you're receiving a good signal quite late when you're talking about the first the gold minute or first minutes of life. And the only thing I can say is that, as far as I know, there is in the pipeline pulse oximeters with a much faster response. And so I've seen some preliminary data showing that you may have a good signal already, maybe within the first minute. So, but I don't have any personal experience with that.
There's a question about stopping resuscitation. As you mentioned, the 2015 NRP suggested to stop resuscitation if there's asystole after 10 minutes. They said it's reasonable to stop resuscitation after 10 minutes. Now, this is reversed in the 2020 guidelines, where they said that you should continue for 20 minutes. The question is, what happens if you still have bradycardia, but not asystole, after 20 minutes of life, and the babies, continue to have a low heart rate, but there is a detectable heart rate? What should the team do?
I think the most data are about if you don't have any heart. For instance, the previous recommendations stopping after 10 minutes was based on studies where you didn't have any heartbeats the first 10 minutes. As soon as you have a heartbeat, let's say the first 10 minutes, we don't have data. I have myself many times been in this dilemma, and you have baby's bradycardic, and I've continued to do, for instance, chest compressions beyond 20 minutes. But of course, I don't think we have much evidence for that. And again, it's a clinical judgment, and that's why I like the 2020 guidelines better, because they suggest that we should discuss when you have reached 20 minutes and you don't have obtained the return of spontaneous circulation. And this indicates that we don't know. I mean, here is an area where we don't have knowledge, and we need to fill this gap, I think.
Thank you. Do you have any questions?
Yeah, I have 2-3 questions. First for Ray. Ray, what is your practice? Actually, we are asking this question because it's not only the high-income countries, there are more than 50 countries this task is going on. What is your recommendation, or what is your practice? You start with Cpap, and which kind of a Cpap, and after, or if the baby intubated, then which mode you are using? I'm talking about less than 28 weeks.
Yeah. So in our practice, we'll support babies even down to 22 or 23 weeks with nasal Cpap, but once you get below 25 weeks or so, kind of thinking about how you're administering surfactant. So in our center in Rochester, Minnesota, similar to a lot of centers in the United States, the main way we give surfactant is with intubation and through the endotracheal tube. We are part of the Aerofac 2B site where they're using nebulized surfactant, so that's an option for some of our newborns that qualify for that study. But for most of our infants, if they're less than 25 weeks, we end up progressing to intubation, but we do it kind of based on the response to the resuscitation.
And after extubation, if let's say baby get intubation for 24 hours, and then which mode you use for after extubation?
Yeah, so for our infants, we do evaluate them for using that intubate, surfactant, extubation, or ensure technique. And then typically when we extubate, we'll first try nasal Cpap, although if the infant is kind of borderline for extubation, we might do NIPPV, or we'll use NIPPV as kind of a treatment rescue if they're not tolerating nasal Cpap.
Sorry, Dr. Ola, I just want to know about this Helix trial a little bit more, because originally I am from Pakistan, and they are doing the cooling the babies. What do you, after this trial, we should do it or we should stop? And they are getting good results from some of the centers. Of course, the availability is only in the big cities, in the metropolitan cities. But what do you think about this ELS trial? In total.
Well, when you see how heated this debate is, it's I think we have to be careful drawing too firm conclusions.
Exactly.
I'd like to say that by reading the Helix article, I think it's a good study. I mean, it's hard to criticize. Some people say that they are looking at different patients than in high-income countries, and they don't monitor EEG, which is true. So they cannot trust their results. But anyway, this was their setting, and it's reflecting. The results are reflecting the settings of these participating units. So what they should do in Pakistan or other countries, it's very hard for me to give any recommendations. I just say that we have to follow the development in this field and maybe do more studies. But I remember the first study from a low-income country. I think it was by Nicky Robertson in Uganda, published in 2011 in the Lancet. And he showed also that hypothermia therapy increased mortality, I think, 6-fold. And so I think that was a warning that we have to be careful. And the reason for this difference between high and low and middle income countries, we can only speculate about that.
We have a question about strategy to achieve ventilation without cord clamping in extremely low birth weight. So how can we ventilate babies without cord clamping if they need to be ventilated and doing delayed cord clamping at the same time?
Well, I guess the question is about whether we could resuscitate or ventilate with an intact cord.
Right.
Yeah. So, of course, that is feasible. And there is one study from US by Katerian and co-workers in San Diego showing that it's feasible. There was no advantage in this study compared to delayed cord clamping. But we know that there are now commercial trolleys where you can do the resuscitation with an intact cord at the bedside. And of course, from a theoretical point of view, there are many advantages to doing that. I think still we have to wait for more data before we really would recommend that.
Okay. Dr. Raymond, there's a question about like when you switch from Cpap to nasal cannula, either high flow or low flow, how you convert the pressure to flow? How do you know that this is that flow that I'm going to use to step down, not step up in the ventilator?
Yeah, and I think that's a great question, and that kind of goes to some of, I think, the art of medicine. There's that various equations like the Wilkinson equation I shared where you can kind of estimate what the pharyngeal pressures might be based on studies in other infants to see if that's kind of a step down in flow if you're going from nasal CPAP to high flow nasal cannula. So that's something people can start with. And I think a lot of us in clinical practice, we kind of get a feel for, what sorts of high flow are weaned from CPAP for babies of certain sizes.
Do you use that formula, or is it something that just to guide you, or it's not really very accurate?
So I've occasionally referenced that formula, but to be honest, a lot of times in clinical practice, I'll just kind of empirically use a certain amount of high flow, like maybe 2 to 4 liters for a baby of a certain size. Going from nasal CPAP of 5 centimeters of water is kind of a wean if we are going from nasal CPAP to high flow. But I think that points that, that's another area where the evidence and kind of the best way to wean babies off non-invasive support is lacking, and there's a lot of different style approaches that are probably all reasonable with the evidence we have.
I have actually comments from Dr. Boris Kramer. It's a comment I'm assuming that's about hypothermia treatment. The comment is we should point out that every center should collect their own data, compare it with the national and international data. Just a comment with one.
Yeah, I think that's a good comment. But still, we need larger materials and randomized studies.
Great. Now we you have any question?
I have one.
Go ahead.
Ray, the different modalities, because Dr. Poling is going to be meeting in tomorrow. And if you ask him, the bubble CPAP and the bubble CPAP and the bubble CPAP. I use personally bubble CPAP in my previous job for a long period of time with a very good. What do you think? What kind of CPAP you are using?
Yeah, so we use CPAP that's ventilator derived. So in our hospital, we use the Hamilton G5 ventilator, which provides our CPAP circuit. But last year, when we were kind of looking at potential ventilator shortages with COVID-19 and kind of a fear that our ventilators might have to go to different parts of the hospital, we looked into bubble CPAP. And some of my partners who have practiced in other settings have used bubble CPAP and high acuity level 4 NICUs and similar regions to where I'm practicing. So I don't think that one way versus the other is that there's a lot of evidence that it's superior or inferior.
And last question to Dr. Ola from my side. Again, the same thing with the end of life decision to stop the resuscitation 20 minutes, because it's happening after 20 minutes of good CPR, and at least in 20 minutes you gave like 4 doses of epinephrine. There's some heart rate, like 30, 40. But if you continue on that thing, I had one study that shows that the chances of 90% brain damage. So, what do you think, that this 30, 40 rates is because of your CPR and because of your epinephrine? You should stop at 20 minutes and just tell the parents that you did everything, and after a few minutes the baby passed away, or you continue like 30 minutes. I mean, it's a real dilemma. I know it's very difficult for all 4 of us to say something, but people are, and Ray, you also can comment on that people are thinking, really want this thing, because nurses and the CPR committee said, no, we need an ACE history from the monitor, then you should stop. So, Aiman, you should also comment, all 3 of you. One by one. From Ola, then
Dr. Ola.
That is a big question, and I think we should have a seminar on that. But, I can tell you that I was not happy with the previous guidelines saying stop after 10 minutes, because, as you know, during a resuscitation, 10 minutes goes so fast. I mean, very fast. So when I was very young, I continued till 30 minutes, but the recent years, I usually stop around 20 minutes if there's no response. Then we also have time to inform the parents, and we have some time to make some considerations. So I feel more comfortable with the 20 minutes limit. But if you ask me about data, I cannot give you much data.
The problem is that when you have some heart rate, like you have a heart rate below 100, but it's not really a very, it's not like 0, but it's like, let's say 60 to 80. So what do you do? Now, if you have a good saturation, the first thing you need to make sure that you're ventilating the baby. So, you're giving good pressure, you have a chest movement very well, and you have no other things that you can fix, for example, pneumothorax or anything that you causing problem with your resuscitation. But stopping at 20 minutes, and if you only have a heart rate of, let's say, 60 to 80, will be a very difficult decision, and it's sometimes, you need to kind of continue a little bit more and then see how it happens, or move the baby, after 20 minutes, just to kind of make sure that you're doing everything that you should do. Maybe do an X-ray or something.
So I never stopped after 20 minutes if there's a heart rate of 60.
Yeah, 60 and above, we don't have that problem.
But how long are you going to go for?
And that's the question. But I'm talking about that after 20 minutes of resuscitation, you have a heart rate of 20, 30, 40. Ray, now it's your turn to comment on that.
Yeah, so I think that's a really hard question, and it also depends a little bit on what's kind of driving the infant need for the resuscitation. You know, if there's a congenital airway anomaly or something like that, where potentially changing your modality of ventilation to high frequency or something, I might consider that. But I agree with what Dr. Saugsted said of kind of that discussion point is so important. And it's something in my clinical practice, sometimes I'll even bring the parents into the delivery room or resuscitation room and have those conversations with them about, if that is my recommendation that we stop resuscitation based on the physiology we're seeing in the baby.
Would you go with their wishes and say, no, we have to continue?
Well, I think that's a hard thing too, and I think that's where you have to kind of sometimes let them know what we're thinking and kind of what we're seeing in the patient. And if the baby's not responding to resuscitation and keeps progressing, if we're continuing it, it's probably not going to change the outcome.
Yeah, I think the main point is that you make sure that you did everything that you should do to make the successful resuscitation. Hypovolemia is not really there. You give fluid pulses, and so it's difficult.
That's true, but also if you go beyond 20 minutes, you may have a blood gas, and you can look at metabolic acidosis.
Yeah. Right now the bicarb is out of the resuscitation. Now the only thing that NLS they say that you can give bicarb if you're really 100% sure that this is a cardiac origin need for resuscitation. You can give bicarb, but the NRP, no, you can need that.
But do you know if the base deficit is not too high, maybe the prognosis is better? So.
Thank you very much. This is really very hot topic, exciting, and we can just discuss this until tomorrow. But I think we have covered the important points. I'm sure you're going to get a lot of more questions coming our way. Thank you very much for taking the time. We really enjoyed this session. This is really a very good start for the day. Please continue to be with us if you're not too late. Actually, for Dr. Raymond, it's the beginning of the day, so you can stay with us.